Hi, everybody, and welcome to our second event in this series on developmental and epileptic encephalopathies. In case you haven't attended our first meeting, my name is Donna Walsh, and I'm the Chief Executive Officer at the International Bureau for Epilepsy. So the agenda for this evening is a very simple one. I'm going to ask our three experts who are with us this evening to introduce themselves to you in a second. We'll then run through our pre-submitted questions, and we hopefully will have a little bit of time to then take the live questions that you may pose throughout the evening. You can then hear what we've got planned in the coming weeks as a follow-up to these webinars. And if you have any further suggestions, questions that you would like to pose to us, we will collate them at the end of the meeting. So I'm going to stop sharing my screen now, and I'm going to invite each of our experts to introduce themselves to you very briefly, and then we'll get to the questions. So Christina, maybe we will start with you, please.
Great. Hi, it's a pleasure to be here. Good evening and good afternoon to some of you. I am currently the chair of the Rare Epilepsy Network, and I've been involved in rare epilepsy advocacy for almost 2 decades. I have a 37-year-old brother with Lennox-Gastaut Syndrome. I founded the LGS Foundation in 2008 and served as executive director. And I currently advise for Families SCN2A and sit on the board for Coalition to Cure CHD2. So I have a lot of experience specifically in the DEEs and the rare epilepsies. Again, thank you so much for inviting me. It's a pleasure to be here.
Thank you, Christina. Keta, I'm going to hand over to you now. Ladies first.
Well, my name is Katia Valente. I'm a professor at pediatric neurology at the University of São Paulo, Brazil, and I am the current chair of the Pediatric Epilepsy Commission of the International League Against Epilepsy. That's writing guidelines for treatment for Dravet, infantile epileptic spasm syndrome, and Lennox-Gastaut syndrome. Thank you.
Thank you, Keta. And Scott, we'll come to you.
Yeah, great, thanks. I am Scott Perry. I am the head of neurosciences and the director of the Justin Institute for Mind Health at Cook Children's Medical Center in Fort Worth, Texas. I'm also the director of the Genetic Epilepsy Clinic, the president of the Pediatric Epilepsy Research Consortium, the president-elect of the Child Neurology Foundation, and a member of boards of the LGS Foundation or medical advisory boards of the LGS Foundation, Dravet Syndrome Foundation, and I could name multiple other rare epilepsy conditions that I serve on advisory boards for. So happy to be here.
Thank you so much, Scott. And we have sent everybody's bio to the participants this evening, so they'll be able to read the long list of affiliations and titles that you guys have amassed between you. So as everybody can see, we have some experts with us this evening, and hopefully we'll be able to answer all of the questions that have come in over the course of the last few weeks, as well as maybe some of the questions that arise this evening. Scott, I'm maybe going to start with you and ask a really basic question, which is, what is a DEE or a developmental and epileptic encephalopathy? Are there symptoms that are common to all of the DEEs, and how do you differentiate between Dravet, TSC, LGS, and so on?
Sure. Yeah, that sounded like a simple question until you got to parts 3, 4, and 5 of that question. But yeah, so I think the way to think of a developmental and epileptic encephalopathy is really in 2 parts. So these are conditions that have an epilepsy component, right? They have seizures, and the seizures in and of themselves will cause problems. For instance, learning problems, right? That is part of the encephalopathy. But there's also a developmental encephalopathy, meaning the underlying reason for the condition. So for example, in Dravet syndrome, the underlying SCN1A variant also causes some of the problems of the condition. And what's important about that is because that means if I, as an epileptologist, fix the seizures and fix the EEG, I did not fix the underlying developmental encephalopathy portion. Okay, so that's why that DEE is different from an epileptic encephalopathy or just a developmental encephalopathy. As far as the conditions you ask about, they are different conditions. They may have different reasons for the conditions, Dravet is primarily caused by variants in the SCN1A channel. TSC, Tuberous Sclerosis Complex, primarily by variants in TSC1 and TSC2. Lennox-Gastaut Syndrome from a variety of different etiologies. But they do have a lot of common characteristics. They tend to have, epilepsy is very common. They tend to be epilepsies that are difficult to control, and they often have much more than seizures. So developmental or cognitive delays, behavioral comorbidities, sleep issues, GI issues, autoimmune issues. It could go on and on and on. Each one may have different collections of those ancillary problems other than seizures, but they generally are more than seizures, that's for sure.
Thanks, Scott. And actually, we will come on and talk about those wider sets of problems that people with DEEs may face in a while. But actually, some of the questions we did receive were specifically related to seizures. So we might start there. And Keta, maybe I'll bring you in at this point, because one of the questions we received was, how would you treat cluster seizures in the home?
There is no universal plan. One size does not fit all at all. It is completely individualized, and it has to be pre-established by a healthcare provider with expertise. Also, you have to be sure that the parents understood, and there must be a seizure plan. And the seizure plan must comprise what is a seizure cluster and what for this child, and what is a seizure cluster that demands intervention for this child. Otherwise, we will treat everything. Okay? The proper medication is age-related too, and there are some social issues. For example, diazepam in an older adolescent is not okay. And even a child, the same child over time, may need different doses and different types of interventions. Like, I'm treating now, but I wouldn't treat there. So it's completely individualized, and it's easy to understand. If you think about spasms come as clusters, but we don't give rescue medications for spasms, right? And CDKL5 always clusters, but then we have to consider in a child with CDKL5 in certain circumstances, and more important, when it's time to treat and when it's time to stop treating and seek for emergency. This is what I would say.
Thanks, Keta. And maybe building on that point then, if I come back to you, Scott, there was a question around whether treating status epilepticus in DEEs differs from other types of epilepsy.
I think it's fair to say there might be some differences, and the difference I would point out is that first, many of the DEEs are prone to status epilepticus, more so than some of the other epilepsies. So being aware of that is really important. And like was just said, is having a seizure action plan. Frankly, it doesn't matter what kind of epilepsy you have. Everyone should have a seizure action plan. But you certainly should in the DEEs. And then defining, just as we just talked about for clusters, when you intervene is important. So there are certain conditions, again, within the DEEs, I'll use Dravet syndrome as the best example, who are very much prone to go into status epilepticus. We know this. And so when we know that, and we know certain situations are likely to put them into status, there's no need to wait, 5 minutes, which is the magic number that many people often use, right? Because the sooner we treat, the more likely we are able to get control. So there's no need to wait in those situations. And but that can be individualized for every child. So a child with LGS, you may know, is prone to go into status in certain situations. So you should have a plan for when that situation is that you want to react. But like I said, I think the main thing is just being aware that DEEs have a higher likelihood of status often. And so making sure there's always a plan is really important.
So the DEEs have a higher likelihood of status epilepticus. Do they also have a higher risk of SUDEP, Keta? One of the questions we received was whether sudden unexpected death in epilepsy is more common in DEEs, and is there anything that can be done to lower that risk?
Actually, it is. It is more common. We know now that the risk of SUDEP is equally high in children and adults. In the past was for adults, children is quite rare, and now we know that's about severity, not age. And when we speak about disease, we are speaking about severity of epilepsy, and the rates are the same. Major risk factors, there are some that we can control and others that we cannot control. The most critical risk factor is tonic-clonic seizures, bilateral or generalized, it doesn't matter. So this is our major goal during treatment, and nocturnal seizures, mainly tonic-clonic seizures. But there is, as Scott mentioned in the beginning, the underlying condition. So there are genetic factors. Some pathogenic variants that predispose to cardiorespiratory dysfunction and autonomic dysfunction, they also cause DEs. As an example, we have SCN1A, Dravet. Okay, so in Dravet, we have an increased risk of seizure burden, drug-resistant epilepsy, and also altered autonomic and cardiorespiratory dysfunction. So we have everything. It's the package. What can I do to prevent? Well, about seizures, we can try to treat as fast and as accurate as possible. We try to control the tonic-clonic, and we advise for nocturnal supervision and also for adherence to treatment, which seems simple, but it's not. There are usually multiple caregivers, place where the child may stay or not. So this is the importance of discuss SUDEP. About the underlying mechanism, there's nothing we can do. So we control what we can. And the genetic factor, we have to at least to inform parents. Some pathogenic variants are more likely to cause SUDEP than others.
Thanks, Keta. We have a question here, changing tack a little bit around absence seizures. And the question is, how do we distinguish between absence seizures and potentially some of the comorbid conditions like autism or ADHD that might be present in a child who has been diagnosed with a DEE? Do you want to say something about that, Scott?
I would love to. This is one of my favorite topics. All children stare. Not all children have absence seizures, okay? So how do you tell the difference? Well, absence seizures are discrete events, okay? Generally, when a person has absence seizures, first of all, they have a lot of absence seizures. So you are having frequent episodes of staring. These are events of sudden cessation of activity, sudden cessation of speaking, where they will stop. Oftentimes, you may even see some rhythmic movement of the head or the eyebrows, and then they immediately resume their activity. So while these events may initially be confused with daydream or things like that, because they're so discrete and occur over and over and over again, I think you will tell the difference with some time. Now, there may be some other things you can do. When you see children staring, and you want to understand if they are alert, or right, or they're conscious during the event. You need to do things to interact with them. You need to, do verbal things like call their name. But, a lot of kids stare even when you're calling their name. I think everybody who has children knows this is true. So then you go and you need to physically interact with them. I always tell my patients there's a few things that most people cannot ignore. Usually tickling the collarbone or under the arm is difficult to ignore. So if you have a child that's doing that frequently and you do that and they're like, hey, stop, get off me, or, there's, whatever, they react to you in some way, that helps you kind of differentiate if you're truly dealing with absence seizures or inattention, slow processing, autism and staring, all the different other kind of things we might see with DEEs. So that's the high level overview of how you tell the difference.
Thanks, Scott. So before we move away from seizures, I want to bring you in at this point, Christina, because I think one of the questions that we've had a few times is, what can we do to increase seizure awareness amongst the general public in our communities? Because a lot of these children have issues participating in education, in social activities, because the level of seizure awareness is not sufficiently high and people don't know what to do when one of these children has a seizure. So any thoughts around how we can get that message out there and we can better equip these key people to be able to intervene and to help?
Absolutely. Actually, I'd like to circle back on the seizure action plan because I think that that's an excellent resource and it sort of answers your question, but also dovetails with the previous discussion. And so for those on the call that may not be familiar with seizure action plans, these are essentially documents that you as a caregiver or patient can fill out that you essentially carry with you in the event of a seizure. And what's neat about them is that they are that there's PDFs that are fillable that you can download. They're available in multiple languages. If you are interested and want to explore what they are, you can go to seizureactionplans.org. And again, they're in multiple languages, so Korean and Vietnamese, Ukrainian, English, Spanish, etc. And again, it's just a sort of an instruction manual for what to do when somebody has a seizure. So that's one, I think, resource that's really important to know about. The other is through the Epilepsy Foundation. For those that live outside of the United States, the Epilepsy Foundation, while they're based in the United States, they have resources that are available also in a number of different languages. And one of the things that I wanted to call attention to specifically are seizure first aid resources that will walk you through what to do in the event of a seizure. And these could be printed out or used, through the mobile apps or the website to really inform people that are working with people with epilepsy. I mean, what I think about a lot of times is school nurses and teachers on the elementary level that may not be familiar with epilepsy. And so those are excellent resources as well. And so there are many others, but I know we don't have time to go over all of them, but I would start with at least those two websites just for some foundational tools.
Super. Thank you, Christina. I see that Ellie has already put the Seizure Action Plan's website in the chat. And if there are any other websites or resources that you want to pop in there, feel free. But obviously, we can send some of those links and resources to people after today's meeting as well, if they're interested to receive those. So I'm going to jump away from seizures for a second and revisit some of the challenges we spoke about in the introduction. And Keta, this is a question for you around whether mental health challenges are actually a symptom of the DEE, or do these people who have been diagnosed with DEEs also have coexisting mental health conditions?
Well, DEEs are multisystemic disorders. And the neurodevelopmental delay and issues, they are part of DEEs. So we like to say that these mental disorders, they are coexisting disorders. So as it was said before, it's part of the underlying mechanism. And let's understand this easily. SYNGAP1 was first described in children with autism, not with epilepsy. And now is DE SYNGAP1. Okay? But the rates of autism, they are higher than epilepsy. And behavior is a major problem, even more than epilepsy. So in the synaptopathies, especially in this group, we'll have an overlap. The genetic architecture of intellectual disability and autism overlaps huge with the DEs. So there is no way TSC1, TSC2, the same. We even have children with intellectual disability or autism without epilepsy and TSC2 pathogenic variants. As a symptom, sometimes, because if you have more severe epilepsy and if you have inadequate or improper treatment, you may aggravate and cause cognitive decline. We have evidence, especially from Dravet, there is the prototype of DEs, that if you use the wrong medication, like for example, sodium blockers, these children will have lower IQs, more aggressive, more behavioral issues. So as a symptom, yes, it is true, but mainly as part of the disorder.
Thanks, Keta. And actually, Scott, I might bring you in to expand a little bit on that, because we had a couple of questions around, should you treat a child for their DEE, but also simultaneously provide them with treatment for ADHD or autism or depression? Thoughts on that?
Thought is yes and yes. Yes, you need to treat the symptoms. All right. So as I said in the beginning, if we treat the seizures, and luckily we're getting some better meds that are giving us meaningful improvements, we still have these other problems, and they do need to be addressed. The way to address that is, in some cases, medication. Sometimes we need to treat ADHD. We know it's very common in a lot of these conditions. Let's treat it early. They have autism and maybe, aggressive behaviors and things like that. Let's treat it early. The earlier we treat those symptoms, the more likely, if we can get some improvement, that we would see benefit from all the other things we do. As I tell many of my patients, that with Dravet, who have significant hyperactivity, if we can't control the hyperactivity, how can I expect them to improve any at physical, occupational, and speech therapy that they're not going to pay attention to for more than a few minutes, right? But as I said, it's not just medicine. There's other ways to treat things. So there's definitely, behavioral therapies, ABA, for example, that we use in autism. You need to think about those non-medicine approaches. Sleep is often a common comorbidity problem in DEEs, both difficulty falling asleep and maintaining sleep. And of course, all of that has adverse impact on subsequent behavior and other things the next day. So making sure you're focusing on that and improving that as well is important. But yes, fixing the seizures or focusing only on the seizures is not going to solve all the problems. You must address the other problems as well.
Yeah, you mentioned behavioral therapy. We did have a question on that, but I think you've covered it in your response there. But maybe I'll put the next question to you also, Scott, because this came in from a parent who was concerned about their child who was taking multiple medications and was asking, how can you monitor issues that might arise due to drug interactions or side effects of medications, and ensuring that you're keeping tabs on that as well as symptomatic improvement?
Sure. Yeah. I mean, that's a team effort. So first of all, when you and your physician choose to add a new medication to your regimen, the first thing you should be doing is just kind of cross-checking and making sure we understand where interactions are present. There's certain drugs that maybe are a little more common where that is meaningful. All right. So in Dravet syndrome, we use fenfluramine as one of our newer medications, and that has a serotonin mechanism of action. So using some of the medications we use for mental health that also have those mechanisms of action can bring about something called serotonin syndrome. So being aware of potential interactions and what the symptoms are is the first thing, so that the parent can be looking out for that. The pharmacist always plays a role too, right? So it's pharmacist's role to cross-check interactions of medications and to alert physicians and caregivers when they're present, just so we can, it doesn't always mean they're meaningful interactions that we need to be super worried about, but it's always good to bring them up and recheck and make sure we're very happy that we feel safe with that combination. But yeah, the main thing is just being educated on the possibilities and knowing what to look for when it occurs.
Thanks, Scott. Keta, a very specific question around side effects of medication that has come in is around, how do you manage weight gain in a child that is taking one of these medications?
Well, weight is important because may impair gait. This is something that we neglect, but should not be neglected, because children that are overweight, they stop walking. But the first thing is also children with severe epilepsy, they are less exposed to physical activity. And sometimes some good dietary or health dietary measures are forgotten. So the first question is always, is it medication related, really? Because sometimes it's not, okay? The second thing is, how important is the medication? Because in children that receive 2, 3, 4 medications that we should not prescribe more than 3, sometimes medication is always there. Valproate is an example. How long has your child received Valproate? For life. Is effective? I don't know anymore. And sometimes you can just, taper and it's okay. If it's key for seizure control, if it's really essential for seizure control, then you have to change the environment. Dietary measures, a dietitian, more exercises, and even some drugs to regulate appetite. And just remember that children will eat what they have. Sometimes changing what you have available, it will cause a loss of weight.
And before we move on away from treatment, just a couple of questions I've seen come in on the chat and on the Q&A. Keta, there's a question here around, are you using melatonin for sleep disorders in DEEs? We've also had a reply in the chat to say that for some it may trigger seizures in the morning, so they had to stop. So maybe your thoughts on that.
I use melatonin. I use a lot, very often. I don't use high doses. There are recommendations that after 0.2 milligrams is not effective anymore. We have here pharmaceutical grade melatonin. We have to be careful with the type of melatonin that you use because we have garbage in the market, so be careful. And the melatonin has an accumulative effect. The more you use, the more you see your results. And is also associated with a good routine. So using always in one specific time, like in your house, it's 8 or 9 or 10, I don't know. But you have to establish and then turn your lights off and try to create this environment of sleeping. This is the best way. And after 1 year, you have better results than in 3 months or after 1 week. This is something to keep in mind. At least I use like that. I would like to listen from Scott.
Scott, do you want to contribute on that one?
Yeah, I was just going to say, I agree with the comments about melatonin and agree and just want to emphasize the other part, which is that many times in the DEEs, the sleep issue is very much a behavioral sleep issue. And so, and it's no one's fault, right? This is a bad situation. You have, you have a child with an epilepsy that is severe, where you need to keep an eye on them in sleep. So they end up sleeping in environments that are not ideal for learning to sleep. They're sleeping in their parents' bed often. They're being held by their parent and they fall asleep with their parent, and then their parent puts them in the crib or whatever. Well, it's not a good environment at all to get good sleep habits. So I try to make sure that any of the children I take care of with DEs that have sleep problems, I certainly use melatonin to help initiate sleep, but always make sure I work with my sleep psychologist and team to kind of look at the sleep environment and try to get the best environment we can for the situation that we're in, understanding there are some limitations to it.
Thanks so much, Scott. Another question, maybe sticking with you, Scott, and Keta, if you want to come in on this as well, that's come in from Yelena, is around pharmacogenetics. And she's asking, does it only apply to absorption of medication, or can it tell us more about what drugs will work for specific seizure types?
Yeah, so I will say, as far as pharmacogenetics go, I don't use a ton of that right now. It is used fairly extensively in the mental health realms right now, and certainly really helps people understand which medications may be more likely to cause adverse effects, which medications maybe require higher doses for that patient because of the way they metabolize the drug. And some of that can certainly be extrapolated to the epilepsy world as too. I can see ways in which it's helpful. It's not something that is commonplace right now in epilepsy, that we are doing it.
Yeah, we have to have in mind that this type of exam is used mainly by psychiatrists. And in psychiatry, almost everything is empirical. And I think in epilepsy, we live in another era. So it's completely unneeded, unnecessary. So, okay.
Thanks, Keta. And there's 3 different questions around LGS that have come in through the chat and the Q&A, but I think ultimately what we're being asked is, what's the most effective gold standard treatment for LGS? 4 questions now, I think, on that one. So Scott, Keta, whoever wants to take that first.
Sure, I'm happy to take a stab at it first. What is the gold standard treatment? There's not really one. There are definitely recommendations out there. There are drugs that are approved in LGS. That's important to know. Okay, that means they've gone through clinical trials in populations of people that have LGS, and so we have a good understanding of the seizure control that might be obtained, what types of seizures might respond best, and the adverse effects that we have. There are some consensus guidelines and expert opinions on, which ones of those are the best, just in general. But I will tell you, for a patient with LGS, there's still a lot of specificity to it. It's still about the patient, what kind of seizure they're experiencing that is most troublesome to them. So I don't see a patient with LGS and say, oh, you've got LGS, this is the first thing we always treat with, because if that's not the best drug for that child's seizure type that is most troublesome to that family, or the adverse effects are contrary to their goals, then that's not the first line treatment. So I think that's the first important point. And then there's medicines obviously beyond the ones that are approved for LGS that may still be very effective in LGS based on the seizure types they have. And of course, medicines are not the only treatment. There are dietary therapies that are the treatment for LGS. There are surgical treatments that can help with LGS, like corpus callosotomy, and now neuromodulation devices like thalamic stimulation. And then there's vagus nerve stimulation. So there's multiple approaches. So when you're talking about the best treatment is the one that aligns best with the goals of the patient, that meet those goals with the least, adverse effects. That's it.
Thanks, Scott. There was a question around, can sodium valproate, levetiracetam, and risperidone be used as a combined treatment for LGS? A yes or no answer on that one?
It depends on the child. Risperidone for behavior. And if the child is responding to valproate and levetiracetam, great. I don't see levetiracetam as a great drug for Lennox, but if you have a good experience, if the child is improving, great. Okay, there is no problem in this.
Thank you, Keta. I'm going to move away from that for a second. We can come back to it again later if we have time, but there's a short question here. I don't know whether it will require a long answer, but what is forced normalization? That's for you, Keta.
I know. Well, this is a very controversial concept, actually. It's quite rare. It was introduced in 1953. And the concept would be that if there is an improvement in epilepsy and on the EEG, then there is a worsening, and in that case was described as a psychotic state. It was coined for psychosis, and then was seen and repeatedly reported in surgical series, okay, especially in temporal lobe epilepsy. So you had an improvement, a great improvement. The EEG was at least 50% better than before. Absence of seizures for at least 1 or 2 weeks, I don't remember. And then you had a psychotic state. It's very controversial if it is all the same, but has been used in a broader way, like seizures improve and behavior is worse. And it happens. Actually, it does happen. And I don't know if you can use forced normalization for this condition. It was not coined in this sense. but we see this a lot. I don't know why it happens. This forced normalization phenomenon would be about the imbalance between glutaminergic and GABAergic activity and also more dopamine. Is speculative, is a hypothesis. It has been demonstrated in animal models, just that. But for these, in the context of these, we have this situation. Even in clinical trials, we see it happen. If it's because of an underlying mechanism, or if it's because when you improve seizures, the cognition improves too, the child is more aware of everything that is happening, and behavior gets worse. So an indirect consequence, I don't know. I don't think anyone has the answer. Okay, but it may happen.
Thank you, Keta. That's an interesting concept that I guess we could explore for a lot of time, but I'm going to move on to you, Christina, because I think even just the last 10 minutes, at some of the issues we've been talking about, clear that DEEs, present quite a complex picture and must be a huge burden for the caregivers and the families, as well as the person diagnosed with the DEE. Question came in around what strategies can we suggest to these families to help them to cope in their role as caregivers?
I think the importance of caregiver to caregiver communication, that interpersonal communication between caregivers, cannot be understated. And so if caregivers have the opportunity to connect with others, whether that's in person or through computer mediated means such as Zoom or through a Facebook page, or if in person at a family conference, I think that can be invaluable, because sometimes you feel very alone and that you're sort of in the trenches fighting the fight of the DEEs in a very isolated way. And so when you're able to connect with other families and share your experiences, it can really elevate that feeling of social support and decrease those feelings of isolation. There are so many different DEE organizations across the world that offer things like Facebook pages or family conferences, or just ways for families to be able to interact with one another. I know we went almost 18 years without meeting another LGS family, and it was quite isolating. This is before the internet is what it is today. So I would say that is an invaluable resource. The other thing I just wanted to mention is that a lot of times the medical literature really focuses on, seizure burden, as well as some of the other comorbidities as well. But the lived experience of families is incredibly important. And so there's been this shift, especially in the United States and the FDA, to really understand the lived experiences of families and to publish on that. So it's very much validating for a family who has, say, CDKL5 to pick up a medical publication and read what other families are going through in a validated sort of way. And so that is there is that shift that's moving towards that way, which is really nice to see. But the interpersonal support, invaluable for sure.
Thanks, Christina. I'm going to move on. We've a couple of questions around kind of progression or regression when it comes to DEEs. I'm actually going to merge two questions together for you, Keta. Somebody has asked, what does regression in TSC look like? And does LGS always lead to mental and physical regression? So you can address that maybe in a holistic way from a DEE perspective.
In Lennox-Gastaut, the plateau and regression is part of the clinical criteria. There is no way. Okay, so multiple types of seizures, cognitive and behavioral impairments is part of the clinical picture. If it's not Lennox-Gastaut. About the Tuberous Sclerosis Complex, actually it has been reported. I'll be brief. There is the tuberous sclerosis associated neuropsychiatric disorder. And it seems that in a subset of patients, especially the most severe with TSC2, okay, in this group, when they get older, then they lose skills. There is a worsening in behavior, there is a loss of social cognition, the language gets worse and executive dysfunction. So even daily activities, they cannot perform. And now the group from UCLA has a series of patients that was 2 series actually with a limited number of patients, implying that there must be some type of frontotemporal dementia. In some patients, not all, and these patients have been examined even with PET scan for tau, and there is some sort of tauopathy, and these tubers have more tau. Then would be a specific type of dementia. But this is ongoing, and we have limited data to say that there is that. The only thing I can say that the most severe patients have a tendency to have decline.
Thanks, Keta. And actually, we did have a specific question around that link between TSC and dementia, which you've just answered in your response there. Scott, another question came in around, is there a way to slow or prevent this kind of cognitive decline, or do we just have to accept that this is part of having a DEE?
Well, I think I don't accept anything. We don't have to, we don't have to accept anything. We have to recognize that cognitive delays and these other comorbidities you've spoken of are certainly part of DEEs, and so it's not unexpected that they occur, but we should always be seeking to improve them in any way we can. So what kind of ways can we do that? Well, one of the ways we can do that is obviously to get the best seizure control we can, right? So I tell my families, and because we can go through a lot of treatments, and I recognize that people at some point get tired of treatments when they fail, but there's always a chance the next one will work, and so it's worth continuing the fight to try to get the best control you absolutely can. At the same time, it's important to know that our treatments can cause problems too. So trying to get the best control you can doesn't mean adding treatment on top of treatment on top of treatment. Sometimes the best thing you can do is less and take things away to improve some of those kinds of problems. Obviously, using medicines that are indicated and not ones that are contraindicated, like Katie referred to earlier, right? Dravet syndrome, don't use sodium channel drugs because we know that contributes to worsening outcomes. And then, doing, the other ancillary things we do, the therapies and things like that, they're useful. They're useful. I understand they get tiresome after a while, and and it's okay to take breaks. But those things can be helpful too. I think they deserve every opportunity they can to get better. And again, always, as long as it aligns with the goals of the patient and the family.
Yeah, I see in the Q&A box, Yelena has asked a question as well around, referring the child on to psychiatric services, psychological support. Is it actually necessary? And it can be difficult to actually explain to the child why they need this kind of therapy and support, particularly maybe as they approach their teenage years. Scott, anything to add in response to that question?
Well, I mean, again, it's a situational thing. Every child is going to be different with how they will benefit from it or not. I mean, if you're talking about something where we're dealing with counseling, for your feelings, you've got to be able to communicate those feelings and understand what's being communicated back to you for those things to improve. But that being said, I think the problem is oftentimes people with DEs don't get exposure to those services. And while your neurologists are probably trying their bestest to help you, we are not psychologists and we are not psychiatrists and we are not developmental pediatricians. And many times, they can have skill sets that we don't have, and ideas that we don't have that are helpful. That's why at my center, we created this environment where the psychiatrists and psychologists and developmental pediatricians are right down the hallway from me, because I recognize I do not know the solution to all these problems. And if I could just walk down the hall and talk to a colleague that might, maybe we could help them. So I think it's always worth, if it's put to you as something that may be helpful, it's probably worth pursuing. Just like meds and other treatments, you see if it aligns with the goals and what you're trying to achieve and if it's helpful.
May I?
Yes,
Just
Keta,
one thing.
Yeah.
The first psychophobia is over. The time to be afraid with the explosion of mental disorders after the pandemic, I think the new generation accepts much better than we. They speak about this openly. Actually, sometimes too much. They are making diagnoses with TikTok and everything else. We have to be careful. But they accept much more. About what Scott, just on the top of what he said, indeed, we have to remember that children with intellectual disability and autism spectrum disorder, they are more likely to have more psychopathology. And we don't know to make the diagnosis of depressive symptoms, mood dysregulation, and anxiety in these children. It's very complicated. And sometimes we have a behavior or aggression gets worse, 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 and then a psychiatrist say it's mood, you know, it's mood. We just have to give something to improve mood, and fluoxetine, few drops, it works very well, but we are not skilled for this. So behavior is a symptom. It's very hard to have behavior as a disorder, and we don't have the skills to distinguish aggressiveness, impulsiveness, mood. It's important. It's essential.
Thanks, Keta. Christina, can I bring you in on that point as well around the kind of mental health side of DEEs for the individual diagnosed, but also maybe for the caregivers and other family members, and maybe your thoughts on its importance and this kind of wider holistic approach to treatment and care?
Well, I can certainly speak to the mental health of caregivers because this is something that comes up over and over again in these lived experience qualitative interviews. There's something called conceptual disease models, which really look at the whole picture of a rare disease. And if we look at some of the publications that have been done in CDKL5, again, I'll use that as an example, it really highlights the burden on the caregivers and their mental health. And so I think for caregivers, it's important to not forget that their mental health matters as well. While I can't speak to the treatment specifically, I can say that mental health is a big factor in caregivers with DEEs and rare epilepsies, and it should be something that's not overlooked.
Thanks, Keta. Scott, before we leave this topic of kind of progression and regression, question has come in around, can these disorders actually be reversed? Can some of these new treatments help us to get back to a state, before the DEE actually took hold?
So that is a question that I hope years from now I'm going to have a more definitive answer for you about, for some of these DEEs. We are working and developing disease modifying therapies. So these are treatments that are not treating just the symptom, be it seizures most often, but are treating the underlying etiology. Because if you remember when we started off talking about what a DEE is, fixing the seizures doesn't fix the whole problem. So I'm not going to reverse the issues if I don't treat the underlying reason for it. Now, that being said, fixing the underlying reason, I don't know will necessarily reverse the problems. It might stop the progression of the problems. It might provide some improvement of the problems. Whether or not, a person who has had a DEE, for instance, for 15 years, I can reduce that 15 years of what they experienced and take them back to normal. I find that hard to believe we'll do it. I don't want to give up the hope that we might be able to do that, but I find that would be difficult. So instead, probably what we want to do is find a disease modifying therapy where we can institute it early in life before these things happen. So preventing them from happening instead of trying to reverse them is probably the direction that is going to be the most likely. But that being said, when you look at some of the data, even from the disease modifying therapies of Dravet, people throughout the age group showed some improvements. So we didn't reverse and correct the problem, but we did help get them on a better path. So I think it's never too late to get better. That's what I always say, especially as it relates to adults who unfortunately don't get all of the things that kids often get, right? It's never too late to have better seizure control, and it's never too late to get better.
Thanks, Scott. Keta, I want to move a little bit away from sort of pharmaceutical treatment, this conversation that we've been beginning to have, and to ask you a little bit about the role that surgery might play in treating DEEs. And in particular, we had a question around the effectiveness of vagus nerve stimulators.
Yeah, in some DEEs, then about surgery. So let's divide in resective, disconnective surgery, palliative surgery, and then neuromodulation, okay? Resective, disconnective surgery. If you have a group of patients, if you have one patient with a focal lesion that can be resected, then it should not be the last resort. This is the message. You should not wait. The earlier, the better. I'm sure that Scott agrees with me. We both come from a center that this is a dogma, okay? So if you think about etiologies in early life, and especially in infantile epileptic spasms and Lennox-Gastaut, that you may have lesions, that we have malformations of cortical development. Sometimes we have hemimegalencephalus. You don't need to wait. Drug resistance is the sooner the better. You can change, really change. This is precision medicine already. A surgery can be precision medicine, can change the neurodevelopmental trajectory for these children. And for tuberous sclerosis, the numbers are 50 to 60% control. It seems lower, but it's higher than any pharmacological treatment. If you have one tuber, then, or even multiple tubers, but one that is more epileptogenic, then go for. The sooner, the better. Just think about that. It's not for all, it's for a subset of patients, but it works. The main goal is to improve seizures, of course, but you may improve other things. Palliative surgery, then we have the callosotomy or corpse callosotomy. We don't intend with palliative surgery to stop seizures. It's not going to happen. But, for example, in Lennox-Gastaut, you may improve disabling seizures. That in general, we use the term drop seizures. This is not a seizure type, but seizures leading to falls. Then it helps a lot. And also, it should not be postponed if you have this clinical picture. It has been used for infantile epileptic spasm syndrome when it's not the first treatment at all. There is the standard of care, but when it doesn't work and it evolves with drug resistance. Okay. Neuromodulation. Neuromodulation, we have reasonable results with VNS. We have different series from 30 to 70%, but in pooled analysis, we say 50% of improvement, and 50% is a lot. It doesn't work fast. You have to wait. And for this reason, we should not think like a sequence. I will start pharmacological treatment, and then if nothing works, VNS. We should think in parallel. Why not VNS and start my treatment? Because it will be refractory, it will be drug resistant. So when VNS start working, it will help me a lot. And it's not ketogenic diet or VNS. You may have both. And it is aggressive, of course it is, but it has to be because we have an aggressive disorder. And there is other forms of neuromodulation like DBS that we have even a trial, the STELL trial for Lennox-Gastaut seems to work quite well. Okay? With limited numbers, but still it's useful.
Thanks, Keta. I've got a couple of questions I want to ask you guys. I realize we've just hit time about access to some of these treatments in all parts of the globe, but I might just do a couple of quick fire questions that we're getting in from the audience for very snappy, brief answers. One, Scott, that I can put to you is, should everyone with a DEE follow a ketogenic diet?
No, I don't think I don't think we're going to put out the statement that everyone should do it. It is a treatment in our selection of treatments, and for some people, it will be very appropriate and should be considered. So I think I would just phrase it that everyone with a DEE should consider the ketogenic diet or modified Atkins diet or the low glycemic diet as an option for treatment. But it's not, by no means is it mandated as a treatment that everyone should use.
Keta, a couple of questions have come in around cannabidiol. Are they effective? Should they be used? What's your opinion?
Pharmaceutical grade cannabidiol, yes.
Yes.
Cannabis, crazy thing, no, because THC may cause even more seizures, and it causes even more cognitive decline. We are speaking about regression. We have evidence that's not good for cognition. But cannabidiol have good clinical trials for Lennox-Gastaut, and in Lennox works better than Dravet, for sure, and tuberous sclerosis. From the three of them, in my personal experience, I think Lennox is the best one to go with cannabidiol, but I tried in tuberous sclerosis too. And in Dravet, I prefer other options, but also it's an option. Yes.
There's a question that's come in to say, we know that some medications will stop working after some time. Could something that didn't work initially, should it be revisited after a period of time, Keta?
Yes, actually, yes, absolutely. And even when we consider that these children will be in polytherapy, in Lennox, for example, we have patients that start with valproate, which is quite common, and then we check again and we use valproate plus lamotrigine. That's a good association for seizures leading to fall or drop seizures. And then it works, sometimes with small dose of clobazam, and I can give you other examples. So yes, and also when we receive a case, patient, we have to check again the doses, because when they are not treated by epileptologists, it's very common that they use high doses, but not as high as we do. And sometimes we need higher. So suboptimal doses, then we can use again and use properly, and we have better results, yes.
Scott, a question has come in around, are certain population groups more likely to have these genetic epilepsies? And this came from somebody who works in SLC 6A1, who noticed that they had no African Americans in their support group, and they wondered if that was an issue around people joining and getting involved, or was it because certain groups are less genetically predisposed?
Sure. Yeah, I mean, I would say the majority of that answer is that it's probably less engagement of the population. We don't really have a reason for these DEs as we understand them for them to respect some ethnic or racial line. So in general, these are communities that are not being reached for whatever reason and not being engaged, and we see this throughout medicine. And so that should be a continued, effort to get them involved as much as possible. They're underrepresented in research, unfortunately, and we really do need to get them more involved. And there are a variety of reasons why they're represented. Some because of their own concerns or fears of research itself. Some because they're never offered it because people make an assumption that they don't want to participate. Which is, may not be the case if they were knowledgeable or educated enough about what the option was to them. So it is an area that deserves a lot of attention.
Christina, do you want to come in on that point and maybe a couple of thoughts around how we can ensure more engagement from maybe more marginalized communities in research, but also ensuring that they're accessing the healthcare that they need?
Yeah, no, Dr. Perry, thank you for saying everything you did, because it's spot on, hit the nail on the head. I think it's very multifactorial, and there's no easy answer. But one of the issues is even accessing genetic testing. And so I think it's sort of like this multi-pronged approach that needs to happen, but because of systemic issues, a lot of people who are underrepresented are not even having access to the genetic tests that can guide them to a specific rare epilepsy or DEE diagnosis. I think that that's an entire webinar for another day, talking about access and inequity for sure.
I think that we have a problem in Brazil that you have in US. Unfortunately, the color of the skin is tied to social classes. This is a social issue. Okay, and minorities, indeed, they don't have genetic testing, they don't have proper treatment, even for spasm, the standard of care they didn't receive. So we have to be more proactive in this sense.
On that, Keta, I might actually come to the last set of questions, which we have seen some mention here in the chat around what work is being done around DEE research in lower and middle income settings, particularly in regions like Africa. How can international patients obtain new therapies or join pathways to be involved in research? Any thoughts from your side around how we can ensure that sort of parity of access across the globe?
No, I advocate for this. This is my mission, actually, to bring trials for middle-income countries. And the question is wrong. Caregivers have to change. There must be a mindset. It's not how do I obtain the drug for my child. It's not going to work because you cannot move. This medical tourism does not work. Just work for the wealth people because they have to afford living and health, having a health insurance that can cover everything. It doesn't work for the population in general. It's not going to work. We need to work as groups to change the public policies in our countries, to create settings or to show that we have settings that can have clinical trials, that we have specialties or specialized people that can conduct clinical trials. If you work together, caregivers and physicians, then you can change a reality. And believe me, it does not take too much. We are doing this right now in Brazil. Okay? We are working together. So this is the way. It's not how can I obtain for me, because it's not going to work even for you. It's how to obtain for us. Then we can bring clinical trials, then for Brazil, for Latin America, and for Africa as well. Africa at the moment has some pathways to make. If the FDA approves, it will be approved there. And there are good clinical settings in South Africa. So this is the question is wrong. We have to change how we think. This is what I think.
Thank you, Keta. And I see Elena in the chat has said it was a pleasure listening to you. It makes her want to bring her son to you for an exam, but she's in Serbia. So unfortunately, not going to be able to make it to Brazil. But I think this is a nice way to end this conversation. And I wondered maybe, Christina, if you'd like to come in on that point as well, because I see Michael has put a comment that saying, you know, patient organizations can be part of this and we can play a role to bring the community together and to advocate for that change that Keta has spoken about. Because even in high income settings, not everybody's got access to these drugs. I'm in Ireland, and recently we had a family sell their house to ensure that their daughter had access to fenfluramine. So, you know, we are in a position where even in parts of the world where we are very high income countries, we're still not getting this access across the board. And I know it's a solution that probably has more of a national solution, but I think that global advocacy can help. And maybe if you all want to kind of give us one last message before we wrap up, because I realize you're all busy and you need to get back to work.
My last message would echo what Katha said. We can't work in silos. We need to work collaboratively, caregivers with physicians, with advocacy groups. The Rare Epilepsy Network is an example of a cross-collaborative network of organizations that are doing just that, trying to move the needle forward. And so if you can find your sort of similar organization in your country or continent, I think, and get involved, that would be a great first step. And if I can help in any way, I'm happy to chat if you want to share my contact information about the Rare Epilepsy Network. But just to reiterate, we cannot work individually. We have to work collaboratively, and not just within our own countries either. We have to work internationally and globally.
Scott, any final thoughts from you?
My final thoughts are that epilepsy is more exciting than it's ever been before. There is a lot of interest in correcting this condition. So I know these are difficult conditions, but don't lose hope. We're making great progress, and we should keep making that progress. And just remember that the best treatment for you is the treatment that aligns best with your goals. And that means that all of these things we've talked about, should all be on the table at all times to consider for therapy. You just have to figure out which one best aligns with your goal.
And Keta, anything you'd like to add?
I think that rare epilepsies, some rare things have happened too. First, I truly believe in precision medicine. We have seen some results, and I'm very enthusiastic. I hope to be alive to see this change. I do hope to be alive. It's nice to be living in this era. It's the only thing I can say. The second thing that is already happening is this: patients and healthcare providers working together. This is magical, and this is also something that helps a lot, all of us. We are learning together a lot. So this is my final message. Thank you.
Thank you so much, Keta. And it's nice to end on such a positive note. Just before we finish, I want to remind everybody that you will remember that we had our introductory webinar. This is our Ask the Expert session, but we also have a third part to this initiative, which is a set of video lectures or our e-learning series around accessing, understanding and disseminating science, because what we heard loud and clear from this community is that it is really essential that we can access, and you mentioned this earlier as well, Christina, access science that's not just about seizure burden, but is really about the quality of life and the needs of our communities and the work that is happening and the inspiring developments and advances that we're starting to see, and how we can actually communicate that effectively to bring that hope to our communities. So we will be releasing those short video lectures starting in January. Many of you have already signed up to receive some of these video lectures. If you haven't, it's not too late. You can just send us an email to the address on screen, and we will be more than happy to add you to our list. So with that, I just want to thank our three speakers this evening, to you, Scott, to you, Christina, and of course to you, Keta. To those of you who have joined us live this evening, it's much appreciated. I realize time zones always make these things problematic at a global level. But for sure, I think it has been a useful exercise, and the recording will be available to all those who had registered afterwards. We will also be sharing more information with you as we develop our plans on the rare and complex epilepsies, or the DEEs, as we move into next year. We ensure that that is integrated in our work at the International Bureau for Epilepsy. And I will leave it at that. I realize we're 15 minutes over time, but I can see from the comments in the chat that everybody's found it a really insightful and interesting discussion. And I see Adam has said the science will help us fight the stigma. So I think these types of sessions where we're bringing the science to the community are helping us achieve our mission. So thanks to everybody, particularly to our speakers, and wishing you all a really nice rest of the day.